Africa. And the study was done between February and May 2016. And I will not discuss the methodology. I will just address the outcomes of this study because they have concerns for us. The first presentation will be on the whole study on perioperative patient outcomes in the cohort of patients that we did. And the second one I'll talk about is the obstetric and neonatal outcomes from the same cohort of patients. I will address those from the African Surgical Outcomes Study. And then I will add another study that was done around the same time, addressing pediatric outcomes, perioperative outcomes in Kenya. That was done in 24 hospitals so that we can get the whole scope of the patients that had been done addressing surgical outcomes. So beginning with the perioperative patient outcomes in the African Surgical Outcomes Study, the global data in that study had 11,422 patients from 247 hospitals in 25 countries, as I had said previously. One of the outcomes there was that there were, looking at the number of specialists that participated in this study, surgeons, obstetricians, and anesthetists, they were a 0.7 per 100,000 population, serving 810,000 people. And that you can see, because compared to the global average, the recommended is between 20 and 40 per 100,000 population. You can see the scarcity of specialists addressing surgery. And the hospitals that did this study, the number of procedures that were done showed that they did about 212 procedures per 100,000 population per year. It is like hardly any surgery is being done. Although this particular cohort of patients was addressing only 18 years and older patients, and was done in only 1 week, 7 days. The other thing
Sorry, Prof, to interrupt. Sorry to interrupt.
Yes.
We cannot see your slides.
Oh.
Yes, you kindly need to share them for us to see.
I thought it was shared by Dr. Kenodia.
No, okay, maybe unless he is. Sorry, but we cannot see them. They haven't shared them.
Oh, can you ask him to share, please?
Okay.
Okay. I think the slides are there. You will need to just guide us on, there's somebody moving the slides. Just advise us when we need to move next. Because here we are showing the scope of the talk.
Okay.
Yes. We were actually waiting for your direction.
Oh,
you can
okay.
see whether we move, yes.
Oh, okay. Okay, just talk about the scope of the talk. You can hear me now. Hello.
Yes, we can. Thank you, Prof.
Yes, scope of the talk. I'll address perioperative outcomes in the ASOS study, and then I will focus on the maternal and neonatal outcomes. And then I will talk about the pediatric outcomes in the other study, that is the third one. And then I'll say something about African Perioperative Research Group. And I mention the ASOS trial that followed the surgical outcomes study, and also mention something about a study on African critical care COVID outcomes study that is in preparation, that we are about to roll out at Kenyatta National Hospital.
We can't hear Prof. Prof, you have muted yourself. You're still muted.
Now?
Now you're okay.
Okay. I was saying the study, can you move the slide, please? I had already said the enrollment into the study was voluntary in the participating countries. And then emphasis was that surgical data outcomes in Africa is scarce. And as I had said earlier, it was the first African surgical outcomes study ever done. Then the other thing we found out was that only a few African countries have national registries or audit systems to monitor surgical procedures and subsequent outcomes. The Lancet Commission on Global Surgery was established to develop strategies for safe, accessible, and affordable surgical care. And there is need to increase access to surgical treatments in African countries. But perioperative complications represent a major global health care burden. There are a few studies. Now, the study of this objective was to provide epidemiological data and volume of surgical activity and perioperative outcomes, and also to determine the surgical workforce density similar to data published in developed countries. The study design was a 7-day international multi-center prospective observational cohort study of patients aged 18 years and older undergoing inpatient surgery in hospitals in 25 African countries. There was no proposed sample size for the pilot trial. The sample represents the minimum number of trial centers that were willing to participate and had full ethical approval at the date determined for the pilot trial. We aimed to recruit as many hospitals as possible using a convenience sampling survey and required data from at least 10 hospitals per country, or have the surgical centers if there were fewer than 10 hospitals per country, and data for at least 90% of the eligible patients from each site. Here in Kenya, we had 5 centers: Kenyatta National Hospital, Mater Hospital, Karatina Hospital, Narok Hospital, and Jaramogi Oginga Hospital. The outcomes we needed were, the primary outcome was in-hospital postoperative complications assessed according to predetermined criteria and graded as mild, moderate, or severe. And the secondary outcome was in-hospital complications and reasons for those complications. In-hospital mortality was censored at 30 days after surgery. Findings: I had said a total of 11,000 patients were recruited from 247 hospitals during the national cohort weeks. And I had mentioned the other findings there that can be found in the papers. And continue. I had talked about the number of the specialists, 0.7 per 100,000 population. And then the surgical procedures per 100,000 population each year, I had said was 212. And it was observed that patients were younger in age, with a mean age of 38.5 years, with a lower risk profile. And that was the ASA classification of an American Society of Anesthesiologists median score. It was between 1 and 2 than reported in high income countries, similar studies. 1,253 patients were infected with HIV/AIDS. 6,504 procedures were urgent or emergent, and the most common procedure was cesarean delivery, 33%. Postoperative complications occurred in 1,977 patients, which was 18.2%. 95% of which one was that? Sorry. Complications occurred in 1,977%, which was 18.2%. 885 patients, 200, I'm confusing this, 239 patients died after the after surgery, infection was the most common complication. And of those 225, 112 of whom can't see this properly. Anyway, with all that data, the interpretation that we made, despite a low risk profile and few postoperative complications, patients in Africa were twice as likely to die after surgery when compared with the global average for postoperative deaths. Initiatives to increase access to surgical treatment in Africa, therefore, should be coupled with improved surveillance for deteriorating physiology in patients who developed postoperative complications. The patients who died were 2.1% of 11,193 patients who are recruited. And 225 patients died after the first day of surgery. That is 95% of those who died. And then complications occurred in 1,100 patients. And that was 95% of those who complicated died. Despite the low risk profile, I had said that earlier, and few postoperative complications, patients in Africa were twice as likely to die after surgery when compared with the global average for postoperative deaths. Initiatives to increase access to surgical treatments in Africa, therefore, should be coupled with improved surveillance for deterioration in physiology in patients who develop postoperative complications and the resources to achieve these objectives. Neonatal and obstetric outcomes maternal and neonatal outcomes after cesarean delivery in the African outcomes study. It is good to note that African population has the highest growth rate in the world, estimated to exceed 1.7 billion people by 2030. Mothers and children continue to die in an unacceptable rate in sub-Saharan Africa, estimated to be more than double the global average of 546 maternal deaths per 100,000 live births in 2015. Neonatal mortality rate is also on the increased and the highest compared, which is at 28 per 1,000 live births, compared with 19 per 1,000 live births in high-income countries. In this finding, 97 3,702 patients were recruited. The maternal patients were recruited from hospitals across Africa in that study. And they were all included in the analysis. And complications also occurred in these patients. The other finding was some of these patients, there was no data included in 107 patients, and complications also were missed in 107 patients in the maternal mortality analysis. The combined number of specialists was the same as in the other study publication. Complications in the maternal study occurred in 633 mothers, and the causes of these were analyzed and included post-operative bleeding, intra and post-operative bleeding, and maternal mortality from this study was independently associated with preoperative presentation of placenta previa, antepartum hemorrhage, and perioperative severe hemorrhage or anesthesia complications. The neonatal mortality was 153 babies, infants, or 4.4%. So the interpretation here showed that maternal mortality after cesarean delivery is 50 times higher in Africa than that of high-income countries, and is driven by peripartum hemorrhage and anesthesia complications. Neonatal mortality is double the global average. It was assessed that early identification and appropriate management of mothers at risk of peripartum hemorrhage might improve maternal and neonatal outcomes in Africa. So those are the African surgical outcome study papers. And then the pediatric perioperative mortality in Kenya paper. This also was a prospective cohort study, which was also observational and was published in an anesthesiology journal. And the background here was that pediatric surgical load in low and middle income countries is growing. There are more than 50% children in these countries, and it is assumed or assessed that about 85% may require surgery. In this study, also there is sparse data on perioperative mortality rate in children. This study recruited 6,005 patients between January 2014 and December 2016 in 24 hospitals in Kenya, and the cumulative mortality 7 days postoperatively was 1.7%. It was increasing as days go by. And factors that were associated with a statistically significant increase in the 7-day mortality were: 1, ASA classification number 3 or more. If surgery was done at night or during the weekend, more children died. And number 3, and this is also very important, implementing safe surgery WHO checklist. The safe surgery checklist is a document that has been circulated in all hospitals, and they found out in this study that the mortality rate is less in the secondary level of hospitals, which is 1.4%, and tertiary hospitals, which is 2.4%. And it was highest when compared with primary hospitals, where it is 3.7%. This was the baseline data found in this study. And this study came out as 1.7%, and it was rated as 100 times higher than the high income setting. Addressing the factors which are associated with the increased mortality in children, it was felt that addressing and developing, establishing pediatric surgical care systems in low and middle income countries, and developing research pathways to address the interventions that will assist in reducing mortality rate are a high priority. So that is the presentation. The slides are not moving at the rate I am speaking. I feel I shouldn't say too much, other than that the African Perioperative Group research group was formed after the ASOS study to address surgical outcomes and improving, reducing surgical mortality in Africa. And many countries signed in. And this is one of the information I wanted to pass on to all concerned, that Kenya is represented in that group. And it came up with 10 research agendas. Proceed with that. And those research agenda priorities will be addressed one after another. After the ASOS study, it was realized that postoperative complications were the source of the high mortality, and it was decided an ASOS 2 trial would be done, and it was done from last year, and November to May this year. November 2019 to May 2020. And this study was formed to address increasing the care of postoperative surveillance of patients who complicate postoperatively. And these patients are the ones that were found at risk of postoperative complications in the assessment that was birthed after the ASOS African Surgical Outcomes Study. And the trial was to improve the quality of care. And the way this was addressed is to make sure that the patients who were thought they would complicate would get higher surveillance. And this involved admitting them in a higher care ward. For example, if a patient scored a score of about more than 10, according to the scale that was addressing the assessment, they would go to a higher care ward than initially would have gone if that scale was not used. And the higher care wards included critical care unit, HDU, and the other intervention was a special part of the general ward where the nurse-patient ratio was higher than the rest of the ward. And then the other one was moving the patient bed from where they were preoperatively to a place near the central part of the ward where the nurses sit, the sister's desk, so that they can see these patients more closely. And the other one was getting a relative to sit next to the patient in the general ward so that they can go and call the nurse from the nurse's desk if the patient is complicating. And there was a scale of what complications were anticipated, and these were put on the patient's beds so that those who are looking after the patients, especially the nurses, would know the complications when they came. So that study was finished in May, and now data analysis is being processed, and we shall soon have the data to share and the findings. So this research group has set priorities, and it will be circulating the next research that people can join in. That is one of the things I wanted to say. And then I wanted to mention the surgical safety checklist manual, which is a publication of WHO, which was done to circulate the surgical safety checklist because it was found, like I said in the pediatric outcomes study, that where it was not applied, more patients died when it was not applied. It was a risk which was significant statistically. The aim was to reduce the number of surgical deaths across the world, and at the same time to harness political commitment and clinical will to address important safety issues. These issues include avoidable surgical infection, inadequate anesthetic safety practices, poor communication among team members, and this one is addressed by the surgical safe surgical checklist. As set, this checklist addresses a set of safety checks that could be performed in any operating room to reinforce acceptable safety practices and foster better communication and teamwork between clinical disciplines. And this is also a tool for use by clinicians interested in improving the safety of their operations and reducing unnecessary surgical deaths and complications. The African Perioperative Research Group Initiative throughout Africa has over 600 hospitals in over 40 African countries to promote a culture of collaborative and national research in Africa. The ASOS study was centered in the University of Cape Town, and when they sent communication for those who wanted to join, Kenya was one of the countries that joined, and that is how come we benefited with doing this first ever African study, teaming with others. It is very, very important to be on the map, because at the end of the day, what we are interested in to do quality work and to save patients' lives. If we do not take care of the data that has been found out in these studies and see where we can improve, we shall continue business as usual, and then we won't get anywhere. And therefore, the purpose of this presentation was to see how we can improve on the quality of service we give to our patients. And also remember that the quality of service we give to patients also is highly associated and related in the way we teach our students in our training hospitals in Kenya. Now, most of the hospitals do not address factors associated with increased mortality. Established pediatric surgical care systems in low and middle income countries and developing research pathways to address the interventions that will assist in reducing mortality rate will help in care of all our patients besides the pediatric group. We are having a wake-up call, thinking about surgery in our own institution. We have a lot of data, but you will agree with me that the output of surgery at Kenyatta National Hospital, besides the COVID crisis, has been decreasing as the years progress. So this is meant to be a wake-up call, and then for us to address all the things we need to do to improve our outcome and to train our residents better than we are doing at the moment. Because you agree with me, if the study shows that 3% of all surgical outcomes were obstetric, analysis of that data also showed most of the cesarean sections were emergency. You can see the kind of care we are giving. And data addressed further also showed that the complications were more when we delayed interventions. So we need to prioritize research in our institutions. I want to commend Kenyatta National Hospital for having a research department with a funding for those who wish to do their studies. Most of the people that are funded by that group are residents who are doing their dissertations and other willing specialists who are interested in improving the quality of care of patients in the areas where they practice. And therefore, this one should be prioritized, and research funding should be dedicated in the exchequer funding that comes from the Ministry of Health to Kenyatta National Hospital and the University of Nairobi. Ministry of Health should support this research done in Kenyatta National Hospital by the residents and the specialists in the university. The university should get that funding from the Ministry of Health because it is in the clinical area where the university offers service. The other point of note is the ERC, Ethical Research Committee, that is at Kenyatta National Hospital, is very highly respected and evaluates all research that is done there at a very high level. As far as clinical research is concerned, the ERC is requesting the principal investigators in the institution must be qualified with certificates of good clinical practice because of handling human subjects, especially when the clinical trials are being done. That is one other thing I wanted to say. Our aim is to reduce complications and give quality care and give in the research credible data that is worth analyzing during the study, and also determine the methodologies that are right for the type of study that are being done. That is another thing I wanted to say. The last thing I wanted to say is that the dissertations that come out of the residents' studies, now the university is requiring that publications come out of those dissertations as well as they give their dissertations as part of fulfillment of their master's program training. That is another thing that will help enhance research output in our institutions. So I want to acknowledge, first of all the people that participated in doing these studies. There were residents, there were consultants, there were nurses, there were anesthetists, there were pediatric surgeons, and all the other specialties that are represented in Kenyatta National Hospital and other hospitals that participated in all the studies that I mentioned here. All the people that have participated are acknowledged in the publications, and that encourages people to want to continue. So I really would desire for all of us to aspire to have an interest in research and apply for international research funding, whose announcements come regularly, and that way we will interest people to participate, because it becomes a bit difficult for us to do research that is not funded. The ASOS studies were not funded. The little funds that we needed to pay for the ERC came from the Department of Anesthesia. The ACOS study that we are about to roll out has some funding from Kenyatta National Hospital, but as we know, this funding is limited. So let us encourage each other by forming teams, research teams in our departments, so that we can encourage one another in writing proposals for research. And when we do the study, we publish. Like those studies, the ASOS studies were published in high impact journals, Lancet, and the Lancet Global Health, and anesthesiology for the pediatric paper. And then we are waiting now to analyze data for the ASOS trial. And then when we do the ACOS study, we will also publish after we finish. So I want to commend all those people who work day and night to improve the quality of care of our patients at Kenyatta National Hospital and all the hospitals in this country. We should also remember that we are the pace setters, that what happens well at KNH will be spread to the rest of the country and to the world at large. I think I have finished what I wanted to say during this presentation. I want to apologize for the hiccups at the beginning of this study, this presentation. And I want to thank all of you who came to this study. Back to you, Bosire.
Thank you very much, Prof, for that presentation. I think for me, it's quite exciting to say that now the surgical teams are getting involved in research, which I know will make a big difference. I'm checking to see if there are questions, and maybe anyone who has questions can put them in the Q&A section. But maybe I can ask you one quick one if you're able to, if you have the information. The cesarean sections, do you know if they were mostly emergency or elective C-sections? And I just also wondered how we performed as a country relative to the other African countries, if you have that data.
I have that data, but it is not dissected I can only refer people to the publications.
Okay, thank you very much. And I think I was able.
I'll give you one or two insights that as far as the cesarean section were concerned, most of them were emergency. And most of those were emergencies that came from electives that were delayed. Did that make sense?
Yes. Thank you.
And I also
I know you.
There was the issue of hemorrhage. Also, that was highlighted, and all those risks that make the patients die if they are not identified in time. There is delay in intervention.
Thank you for that, Prof. It sounds like we also need to do a lot in the area of improving emergency obstetric care, since that seems to be the one that is contributing a lot to the deaths that occurred post-op. I want to pass on to Prof. Nduati, who has a question too.
Yeah, thank you very much, Prof. Gumi. That's an excellent presentation, and this work is actually really important. I think it's groundbreaking. My question to you, and maybe to also the other people who are here, is this year we know our blood transfusion services have collapsed, or at least they had collapsed from last year. To what extent is were the deaths related to just lack of the commodities? That yes, you will have obstetric hemorrhage, but you should have had blood available as for blood transfusion. The second is maybe I missed it. Was there an analysis of who was doing the cesarean section? Were they skilled enough? Were they adequately supervised? So that it's not, so that we move to more specifics of where we need to have the interventions. Over to you.
As far as blood is concerned, blood is getting less and less as we proceed. First of all, since the blood transfusion funding went down and we had not put in place funding to see how we shall collect more blood from donors. So as far as that is concerned, blood transfusion has an effect, but I don't think it is too much, that lack, because even today, there are a few pints that are reserved in our blood transfusion unit for obstetric emergencies, but not as much as we would have. And then the other one is the patients who die. Some of them are coming to the hospital too late, or they are referrals from other hospitals. Because as you know, we take complicated patients in our antenatal clinic at Kenyatta National Hospital. And those who complicate in other hospitals, they are also brought here. So the numbers go up. But be it as it may, the people who do most of the emergency surgeries in obstetrics, and I dare say in surgical procedures, even in our own hospital, are the residents. And complications that will need higher support by consultants, that is there, but as far as I know, is late in being availed. I am talking about my personal observation and practice, which is not biased. So consultant support in the care of surgical patients is still needing enhancing. And then the other thing I would say is in the postoperative patient, our study found that we needed to enhance postoperative surveillance in the critically ill patients. And these are things we have to plan for. And like I said, in the study that we ended in May 2020, we were trying the interventions that we thought would reduce the death of patients who complicate. So until we do those things, and until we also institute the recommended nurse-patient ratio for HDUs and ICUs, and also all the surgical wards, the nurse-patient ratio in surgical wards should be 1:6. The nurse-patient ratio in HDU is 1:2 patients. And the nurse-patient ratio in ICU is 1:1. That is a dream. I know it doesn't happen anywhere else, anywhere on earth in those ratios, but we can do better than we are doing today. Those are all very, very important. And also to know, also pediatric patients need more care postoperatively and a higher nurse to patient ratio than they are getting just now. So all those things mean that the infrastructural needs, especially equipment and resources, both human and availed things that are needed to enhance timely interventions in surgical patients need to be availed. I don't know how the money from the exchequer is shared in the institutions. It is sent to county hospitals or teaching and referral hospitals. How much is availed to improve on that ratio, such that when the Treasury is allocating the funds, they will take care of the human resource needed for that. It all boils to that, because I said for the specialists group that were taking part in these surgeries, we had 0.7 per 100,000 population of surgical patients. And the recommended is about 20 to 30 to 40 specialists in surgery, obstetrics, anesthesia, besides all the other people that are needed to improve the quality of surgical outcomes. So we also need to improve on that ratio. So this is multifaceted disciplinary measures need to be taken, and taking care of our patients the way we ought. If we don't, we shall continue to wallow the way we are doing at the moment. And it is each one of us, first of all, to own our institutions where we work and desire to give quality care and quality training to the people we look after in our institutions. And then we encourage developing groups that are interested in research so that they can come up with research funded proposals, and also people who are keen in doing research and training others to do the same. That way we shall improve. And when we improve at that, those we turn out year in, year out, we will have improved in their quality of service to the nation. And of course, it all boils up to the health allocated budget, which is nowhere near the Abuja recommendation of 15% allocation from the national pocket. So I don't think I have anything else to add.
Thank you, Prof, for that really very nice presentation and very insightful. I have a question, and actually I have two questions. One of them is the issue of the infection, the complications. They were quite high, about 20%, almost 20%. Yet the population was relatively younger, so in terms of the risk score was should ideally have been even at a lower risk. And unfortunately, quite a number of them, almost 10%, there was mortality. And it seems unfortunate that, again, infection were quite high and it led to mortality. So it kind of just asks, what exactly are we doing? Because you'd imagine that for things like infections, we are in a position where we should be able to prevent this. Second, I wanted to ask a question about that aspect of the support, because you said like many of the mortalities occurred at night, or I think the operations of the mortality occurred at night. And there is that issue of how do you get like the younger doctors or the youngest to get the support from the more senior doctors? What are some of the things we should be thinking about? And I think this applies also at Kenyatta National Hospital, not just in all other hospitals.
Thank you for those questions, Dr. Kenodia. As far as the infections are concerned, remember this was a surgical population we were looking at. And there was quite a high number of patients that were HIV positive and others that had other comorbid conditions. That is another thing to look at. And then the other one is the delayed intervention in surgical patients, such that if a patient comes with acute abdomen, you will still find that patient on the bed 2 days later after they came without intervention. I mean, delayed intervention in the surgical patient who is acutely ill is another reason. The other thing I wanted to say is that there is surgical prophylaxis to prevent infections in all surgical patients. And that one is also important. And then sepsis, surgical sepsis is another issue to address. And it depends on how we handle our patients. And theater environment in the general wards, and also interventions postoperatively when patients complicate. And we cannot run away from the fact that younger doctors attend to the patients first before they call their seniors. I don't know whether this is because they are afraid they will be told they are not studying, but we should remember that Kenyatta National Hospital and other training hospitals in particular, the residents don't have the final say on patient care. The consultant lists are populated with doctors who should be taking responsibility of severe patients, very ill patients, together with their residents holding their hands. That is another thing I wanted to say. The other one is that we need to do ward rounds, dedicated ward rounds in patients we have operated on, and also to follow them up from admission to discharge, whether we were on call on that day or not. And also the other thing I was going to address is that surgical residents should be having in-house calls. I don't know whether they have started, like the critical care unit residents. They sleep in the hospital. They don't have to be called. And you know, these days it is very, very difficult to find accommodation in the hospital, in the registrar's flats, besides the fact that there are more registrars than the rooms where they should be housed in the hospital. But having said that, hospital wards should release the rooms that used to be used by residents to sleep in back to them, so that they can sleep in, so that they don't have to be looked after, so that the patients don't have to wait for a patient to be picked up from Kariobangi South, where the resident lives. I don't know whether this is making sense. And then the vehicles to go and get these people are not many. You pick the people that are needed on the route you are as the driver, and then bring, and then also go to another area. And by the time it is morning, and you have not addressed the emergency, the emergency or emergent situation is hardly addressed. And I am hoping someone is hearing me. The other one, you will remember we have a task force that we recommended to give advice, and we were given that advice, and we are not implementing it. We are not implementing it, and the reason is simple. If somebody is not doing their work, they are not disciplined in the proper sense of the word. They are not. If people don't turn up to work, nobody does anything about them. And I will say this because that is the truth. If we start disciplining consultants and residents and nurses who do not do what they are expected to do, people will get the cue and style up. I think we have to face the bull by the horns. And then the other one also, which is very important, especially in our situation, we have the ability to discipline our own lives. We don't have to be disciplined with a cane. We have to have the integrity that is required of us, and the accountability and responsibility, and know that when we abdicate from our responsibility, and I'm saying this because I have called specialists to come and review patients in the ICU, and they say they are coming, and 48 hours they haven't arrived. Is that how you review a critical care patient? I am ranting. I said we own our institutions and we give them our due service because we are paid at the end of the day. But when we are paid at the end of the day with resources that we do not deserve because we have done nothing, then we need to inspect ourselves. And then the other thing is people, if they form teams to look after each other and to encourage one another in the institution, they will deliver care. They will deliver care. And if they honor the contracts they signed with their employer without waiting for the medical practitioners and the dentist board to discipline them when a patient dies because they were nowhere to be found, we should know this, that a loss of one patient is 100% to that loss to that family. It could be you. It could be somebody else. It is still a loss and 100%. And that 100% is not replaceable. It is not replaceable. How would you feel if it was you and it was your mom or your child? Yes, we never think about it that way. But we really need to know that we are all brothers and sisters at this, whether we are caregivers, whether we are receiving that care. When we have committed ourselves to serve, why don't we do it and do it the right way? And then let us also remember, the Bible tells us, whatever your task, do it heartily with all you have got, as serving the Lord and not men. This is why we are here in our institutions, because at the end of the day, we shall account for what we have done. And the accounting person is merciful and just and righteous. So let us know also, I do not quote the Hippocratic Oath anymore because it doesn't make sense to anybody. And when we are expected to work better than the rest of the population because we said the Hippocratic Oath, in whose name were we saying it? We should ask ourselves that question. Dr. Kenodia. Hello?
Yes, you have answered my question in detail. Thank you.
Thank you very much, Prof, for that. And I think, I suppose you've even raised issues that we often would rather not talk about or discuss about, but they are real, and maybe they are like the elephants in the room that we probably need to think about some more. I know we are sort of like our time is up, but maybe I would just ask whether, I think there was one question that I wondered whether you would be able to say anything about whether you were able to, which Jane Wamkoya was asking, whether we were able to draw any lessons from the high economy countries on how to reduce post-op mortality and complications in Africa? Is it that the checklist maybe is not being used, or it is new to most people? And I know in your presentation you've talked about the patients themselves and the conditions that they had, but I just wonder maybe to what extent the system itself and the infrastructure contributed to these kinds of outcomes, and maybe just the processes within workflows within the hospitals.
Thank you for asking that question. Can I say something about the checklist? The surgical safety checklist is catching on, and it enhances one preoperative preparation of the patient, and also it makes people work as a team, and everybody is personally responsible in that team to deliver a service. And then it makes people know that they do not want to disappoint the team members, that if your surgery is starting at 8 o'clock, the anesthesia team is the first to arrive, and then you go to the checklist when everybody is available for the 3 phases of implementing that checklist. And there is that WHO manual that gives the process of running that surgical safety checklist. That is 1. 2, in the patient preparation, patients should be ticked off from the ward they are coming from as ready for surgery. They should not be put on the list when they are not, even if they were going to go through that checklist. Because if you know the patient has an HB of 6, why are you taking them to the operating room? If the patient has a temperature of 39 degrees centigrade, or a blood sugar of 15, or it has not been done when they are diabetic. All those things are important. And then also the preparation of the operating rooms also should be optimal. Do you have everything that you need, including equipment that you need to perform that surgery, and anesthetic things that you need, and complement of staff that you need to complete that procedure? All those things should be made available. All sterile gowns for the staff who are scrubbing, yes, and sterilizing units that are needed to do that if they are working, or if the equipment are not broken down. Sometimes you have to get linen to go and have it washed in neighboring institutions. All those things are there. And also talking about infection, some of the rooms also need styling up. I hope the areas that need to be addressed are always done and on time. So all these systemic things need to be addressed and there are people to do that. You have administrators in the operating rooms, in the wards, where everything needs to be done. So it is working as a team in the institution where everybody feels they belong and they are delivering the service they were required to or employed to deliver, and they are being facilitated by the employer to do that. I'm saying this because sometimes these things are not there, and not just in the training institutions, referral hospitals, even in the other hospitals, they are not there. And also addressing the nurse-patient ratio cannot be overemphasized. We don't just say that we are okay, we are managing. What are you managing? Are you managing the optimal output that you should be doing? When we go to the reporting of how we were giving the morning reports, we know we don't have enough complement of nurses, and we are okay. We are okay. We are okay all the time. We don't emphasize the fact that we are not happy. When I go to the ICU and find one nurse servicing 3 patients in the ICU, now who does the nurse treat? You are giving drugs, medications to patients late. You are doing other procedures late. Now, is that critical care? In the wards, the drug delivery to the patients ends when you are supposed to be giving the next dose, when you started in the morning. Patients' meals are served late and cold. And patients that need to be fed have no one to feed them unless a relative comes. And even all those things, I don't need to emphasize this. It is every section of the institution that needs to style up. It is not surgical only. I was just highlighting the surgery I know, and the critical care unit I know, because I don't want to be found missing when I should be there. If I don't do that by example, if I don't turn up, the residents will have a field day in the negative sense, because they can get away with it. So, Dr. Bosire.
Yes, Prof. Thank you very much. Yes, thank you very much. And I think it seems like you have a lot of rich data, and I want to believe that probably some other people can come in and use it to like analyze that data to come up with more publications. It sounds like you have very rich data. And so,
one was the initial analysis, yes. And the second one, the surgical analysis first, and then the second one was the maternal and neonatal from the same data.
Yes.
In fact, it can be dissected fast, and because the raw data is also there.
Okay. So I think those in the team, I saw like some few people who are very interested. I believe that they can get in touch with you, especially the residents who might want to use some of this data for their own thesis. So thank you very much. And also thank you very much for that presentation. I think it starts a very exciting journey in the area of surgical research. And we look forward to hearing more about this, and also seeing more people come on board, especially as the research group has been created. And yes, it's nice that you were able to collaborate, not just within the country, but across Africa. I think a lot of our problems are common to the many African countries. So thank you very much for that presentation. Thank you, participants. Watch out for the CPD points in your emails. If you don't see it in your email, please also check the spam folder, because sometimes it lands there. And if you do not, if you still don't get your points within a week, then I think you can get back in touch with us. Thank you, everyone, for being such a wonderful and active audience. And thank you very much, Prof, for the preparation and the presentation. Thank you all. Bye-bye.